Hi, I'm Betsy Nicoletti. Thanks for joining me today to hear about the rules for selecting diagnosis codes when we're doing risk-adjusted diagnosis coding. Of course, the rules, which come from ICD-10 and CMS, are not that different from anything else. But when we're thinking about risk-adjusted coding, we want to make sure we're applying the ICD-10 guidelines and CMS guidance correctly. This presentation is not going to talk about specific codes. Oh, what's the risk-adjusted factor for diabetes or depression? I'm going to talk about the citations where we find the rules from in ICD-10 and the official guidelines, and some risk adjustment guides from CMS, which we're going to see the citations for later on. If you found this on YouTube and you didn't start out at codingintel.com, you can go to codingintel.com and download a 4 or 5 page PDF that accompanies this tutorial. So what is risk adjustment? It is a system that was developed by Medicare and private payers to estimate future healthcare costs. So they had a group of beneficiaries or subscribers, and they said, how much is it going to cost us to care for these people next year? What is their care going to cost? And they used this model that we're going to talk about to estimate what those future costs are. Now it's used to normalize cost, quality, and outcomes in some of our contracts. It communicates to the payer how sick this patient is and our entire panel of patients. Hierarchical condition categories, or HCCs, were developed by Medicare, and they're used by Medicare to establish monthly rates to Medicare Advantage organizations for Medicare Advantage patients. So sometimes you'll hear a presentation where they say, oh, if you make these changes, it's worth another $1,000 a month in payments. That is to the Medicare Advantage organizations, not to us in physician practices. It varies payments. So how much is Medicare going to pay to the Medicare Advantage organization by demographics and diagnoses, and then further by county, by location. But we're in whatever county we're in, we can't do anything about that. It's also used by private payers and accountable care organizations to quantify disease burden of this population of patients. So besides county, they're calculated based on age and gender. Can't do anything about that. Whether the patient is living at home or in an institution. If the patient is dually eligible for Medicare and Medicaid, that can increase costs, so that's factored in. And then what we're talking about, the diagnoses that are submitted on claims in a calendar year, and specifically on inpatient and outpatient claims, physician claims, and other health professional data like social work and physical therapy. It doesn't use the diagnoses that are submitted for laboratory tests or other diagnostic tests. And RAF, that's the risk-adjusted factor. That's what that means. So there's some software. So when you say, what does that mean? Well, the payer adds up the RAF score for any conditions that are submitted in a calendar year by those providers that I mentioned before. And then those diagnosis codes are sorted into diagnosis groups, which are sorted into condition categories and given a risk-adjusted factor. Related conditions are assigned in one category and only the most serious is counted. 2 conditions in the same group are only counted once. A higher ranked condition causes lower ranked conditions in the same category to be ignored. There's some exceptions to that. And then unrelated conditions in different categories are counted and the score is additive. Now, you don't have to know the rules. The software program knows the rules here. And you shouldn't be thinking about these rules when you're coding. So just the second bullet down, 2 conditions in the same group are only counted once. So that means if you have a diabetes with hyperglycemia and diabetes with nephropathy, and those are both in the same group, you don't count the values related to those twice. They don't get added up twice. But that doesn't mean that on the diagnostic side, when we're selecting codes, that we don't put both of them down in the assessment. It just means that they're not counted twice for HCCs. Now, here's something that I do want you to remember in terms of coding, and it's a boost. I should have a picture of a rocket booster here. When certain conditions occur together, the risk increases. So immune disorders and cancer, congestive heart failure and diabetes, COPD, renal disorders, and some certain specified heart disorders, COPD and chronic renal failure, substance use disorders, and certain psychiatric conditions. Someone asked me, does this mean when I submit the claim, when I close the note, that I have to select congestive heart failure and diabetes on the same encounter? And the answer is no. The risk score for the patient is calculated by all of the diagnoses that are submitted in a calendar year by those providers that I mentioned earlier. So if the endocrinologist saw the patient for the diabetes and the primary care doctor saw the patient for the congestive heart failure, both of those count. But if you are treating both of those, or if treating one affects the treatment of the other, then you want to, of course, select them on the same encounter. Conditions are counted in a calendar year. So if a calendar year goes by and you didn't assess that patient for their chronic renal failure, it drops off the calculation for their risk score. That's just what the rules are. I can't say that that makes sense, but that's how these are calculated. So every single year, these conditions need to be reported by someone who's seeing that patient. The gold standard is, in the assessment, you write what the condition is, the status, doing well, slightly improved, not as good as last time, and the plan. Years ago, I worked with a surgeon, a general surgeon, who wanted to put all of the diagnoses on the claim form. Now, we were only allowed 4 back then. I don't want to say how long ago it was, but that sort of dates it. And I said to him, you know, Dr. Fabricant, we get paid the same amount if I put 1 diagnosis on the claim form, you know, hernia, or 4, I add diabetes and hypertension. And he said to me, Betsy, I want the insurance company to know just how sick this patient is. And that is what we want to remember when we're thinking about risk-based diagnosis coding. We are telling a story about how sick the patient is. All right, let's get to the rules. I've been talking forever. So thinking about medical practices, we're going to use rules in section 1 and 5 and 4. Section 1 applies to everything. So sections 2 and 3 specifically relate to facility coding, but they all, section 1 also applies. And you want to be careful that you're looking at the right set of guidelines. So on page 116 in the ICD-10 book that I was looking at, you see that the Uniform Hospital Diagnosis Discharge code set have been expanded to include all non-outpatient settings. So don't use any of those for outpatient settings. It includes all non-outpatient settings. So this is a clearer slide. Section 1 applies to both facility and outpatient. Section 2 and 3 applies to these non-outpatient settings. And section 4, if you're coding for a medical practice, applies to you, outpatient settings. So most of the people who are finding me on Coding Intel are coding for physician services, medical practice services. Section 1 and 4 are what applies. The precedents for assigning codes, coding instructions in the tabular list and the alphabetic index, and then the official guidelines. So follow the instructions in the tabular list and the alphabetic list. So there is a great book, Risk Adjustment, Documentation and Coding by Sherry Poe Bernard. Second edition is out now, published by the AMA. And so I've and she quotes extensively from Coding Clinic, which is really helpful. And this is a quote from her book. As also stated in Coding Clinic in the past, clinical information published in Coding Clinic does not constitute clinical criteria for establishing a diagnosis, substitute for the provider's clinical judgment, or eliminate the need for provider documentation regarding the clinical significance of a patient's medical condition. So the provider documentation is what's important. When we're looking at CMS guidance, these are 3 citations that you should look up if you're doing risk coding. Pay attention because some of the information, some of the guidance in these documents is for facility and some's for outpatient services, and make sure you're looking at the right one. If you Google these documents, these titles, you'll find them. So what does ICD-10 say? Code all documented conditions which coexist at the time of the visit that require or affect patient care or treatment. So code conditions that you're treating, that you're assessing and managing, or if that patient's other condition affects your treatment today, you can't give that antibiotic because of the patient's underlying condition. You can't give the oral steroids because the patient's on diabetes. Then that affects patient care. So we would code those as well. And then do not code conditions which no longer exist. Sounds simple, but we'll see some examples later. From the 2008 CMS guideline document, coexisting conditions, including chronic ongoing conditions such as diabetes, congestive heart failure, AFib, COPD. So they just describe some coexisting chronic conditions. These conditions are generally managed by ongoing medication and have the potential for acute exacerbations if not treated properly, particularly if the patient is experiencing other acute conditions. It's likely that these conditions would be part of a general overview of the patient's encounter when treating coexisting conditions for all but the most minor of medical encounters. So I think this harkens back to the ICD-10 guideline. If the condition affects the care of the problem that you're treating that day, CMS expects it's probably affecting the care and should be included. So CMS is saying there are serious, significant ongoing conditions that have the potential for exacerbation, and these conditions are likely addressed when treating for all but the most minor of medical encounters. And if so, document it in the assessment. So the diagnoses that we're going to add to the encounter, we're going to report chronic conditions annually when they're managed. We're not just reporting them willy-nilly, we're reporting them when our provider assesses them and manages them. But annually, the slate is wiped clean. For chronic conditions with a manifestation or complication, report if they're accurate, of course, and avoid unspecified codes for chronic conditions with spasm, with ulcer, with whatever. If there is a manifestation or complication, use that code. Only a few status codes risk adjust. So sometimes we coders, we never saw a Z code we did not like, but only a few of them risk adjust. And for HCCs, the social determinants of health codes don't have a risk adjusted factor, but they do for some Medicaid programs and for certain other payers. So add those if they're relevant. Those are in the Z55 to Z65 series of codes. So when we got the new 2021 E&M guidelines, we got a specific description of problems addressed. Just remember that the E&M guidelines for selecting a level of service using medical decision-making is different than the ICD-10 guidelines for selecting a diagnosis code. Straight from our ICD-10 general guidelines, The assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. The provider's statement that the patient has a particular condition is sufficient. Code assignment is not based on clinical criteria used by the provider to establish the diagnosis. So when we say, sometimes we question things, just remember ICD-10 tells us that it's the provider's statement is sufficient. And then from coding clinic, clinical verification is an additional process that may be performed along with DRG validation. So here they were talking, this is an old citation, they were talking about clinical verification of diagnoses. Clinical verification is performed by a clinician, RN, CM, medical director, or the therapist. Clinical validation is beyond the scope of DRG coding validation and the skills of a certified coder. This type of review can only be performed by a clinician and may be performed by a clinician with approved coding credentials. So we always have to stay in our own lanes, right? Sometimes I hear from coders, I remove diabetes if the hemoglobin A1C isn't documented. That action's not supported by citations. If the provider doesn't justify the diagnosis and tell me how she gets there, it doesn't count. Also not supported by citations. And we only code the reason for the visit. This action is not supported by citations. So we want to make sure when we're establishing internal policies that we're following ICD-10 and we are following the CMS guidance. This is that same citation from before. Patients with chronic conditions, they're generally managed, and it's likely that they'd be part of an overview of the patient's health when treating coexisting conditions for all but the most minor of medical encounters. So we're going to add to the claim form conditions that are evaluated and treated at the encounter, and chronic conditions that affect the treatment of an acute problem. And really, documenting a treatment plan shows evidence of the assessment and the management. But, sometimes we may require our clinicians write us a book. We don't need that. So you can use information from the history of the present illness that the clinician has documented. And here's the example I always use. Patient comes into urgent care center with terrible poison ivy. And in the history of the present illness, the clinician says, this patient has type 2 diabetes. And the last time she had oral steroids, her blood sugar went up to 560. So the diabetes affects the care of the poison ivy. I forgot what we were treating. So when we get down to the assessment in the plan, the clinician can select poison ivy first and then diabetes. There's no requirement that a condition needs to be documented in 2 or 3 sections of the note. But what can't we use? So take a look at that 2008 CMS participant guide. We don't code from problem lists. We don't code from a list of current problems that were not addressed at the encounter. We don't code from the medication list. Oh, she must have diabetes, she's on metformin. Oh, she must have depression, she's on Zoloft. No, we don't do that. And we don't code conditions that are in the past medical history that are not assessed and managed at that date of service. So sometimes we'll look and see that the patient has a lot of conditions in their problem list, their past medical history, but if they're not evaluated and assessed today, we don't code them on today's encounter. But the participant guide says a code can be assigned on the basis of the evaluation and clinical findings treatment. So what about MEET and TAMPER? Monitor, evaluation, assessment, treatment, assessment, monitor, plan, evaluate, referral. These are not CMS concepts or requirements. They're useful, but not required. And the Optum Risk Adjustment Guide says both of these tools are similar and their usage is personal or organization preference, but is not required. Those 2 acronyms, MEET and TAMPER, do not appear in those CMS guidelines. Now, this is an important change that we got. It made everyone happy. The word with or in should be and it's an old change. The word with or in should be interpreted to mean associated with or due to when it appears in a code title, the alphabetic index, or an instructional note in the tabular list. The classification presumes a causal relationship between the two conditions linked by these terms. The condition should be coded as related, even in the absence of provider documentation explicitly linking them, unless the documentation clearly states the conditions are unrelated. So I've been talking about diabetes. I should have used some other examples here, but here we have from the index. If the linked condition is in the index term under the main term, the coder can assume a causal relationship. So if in the assessment, the physician chose diabetes type 2 uncomplicated E11.9 and also chose a code for a cataract, I can assume that they're related following the ICD-10 guideline and select type 2 diabetes with cataract. Now, this assumes that we have a coder looking at those two assessments. Often it is the clinician themselves, and we as coders aren't going behind them and coding every single encounter. So linked with, if a linked condition is in the index under the main term and you have someone looking at the diagnosis codes, the coder can assume a causal relationship. You don't need to go back to the clinician for that claim. Some groups set an alert so that the clinician can update the problem list. So next time it'll be soon done. Now, how about the ICD-10 guideline? Do not code conditions that no longer exist. We see this all the time. The patient comes out of the hospital and is seen in follow-up for a stroke. The clinician searches stroke and up comes I-63. That should be used when the patient is actively having a stroke. When they're seen in follow-up, we're going to use either sequela of stroke or Z86.73, personal history of TIA and cerebral infarction without residual deficits. And the same for TIA. Patient had a TIA last weekend, 6 months ago. We don't continue to assign it. Neoplasm, I'm going to talk about again in the next slide. Patients seen after greater than 28 days after an MI. We don't use the patient is having an MI now after 28 days. We use old MI, I-25.2, and then any cardiac conditions. Often the patient has some other cardiac conditions. That's why they had the MI. We add those. For malignant neoplasms, we only code the malignant neoplasm, prostate cancer, breast cancer, whatever, if the patient has evidence of the disease or is receiving treatment. If neither of those are present, use personal history of malignant neoplasm from code Z85. Sometimes clinicians say, well, we use the surveillance for this condition is 3 years or 8 years or whatever. That doesn't matter. If the patient is receiving any treatment, taking tamoxifen, taking a hormone for their prostate cancer, then we continue to use the cancer diagnosis. But if they have no evidence of the disease and they're receiving no treatment, no chemo, no oral medications, whatever, then we use personal history of malignant neoplasm, Z85, there's a bunch of them. Leukemia and lymphoma patients in remission should still be coded with active disease. So of course, we want all of our codes to be accurate and specific. I did a little survey recently for Encoding Intel about who's getting denied for unspecified codes, and laterality was right up there. But for conditions in the problem list that are chronic and long-standing, we want to make sure we're being very specific. And if they have a with spasm, with ulcer, or if they're defined by severity, stage 3, stage 4, we want to make sure we use those. And then you add an additional diagnosis following ICD-10 rules. So if it was diabetes with chronic kidney disease, then you would add a specific diagnosis for the chronic kidney disease by the stage. So develop your policies based on these official citations. The coding clinic states that clinical verification is distinct from coding and is performed by clinicians. So talk with your medical director if you find yourself removing diagnoses. ICD-10 says the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. So if you are watching this on YouTube and you didn't find us on Coding Intel, I invite you to go to Coding Intel right now, take a look at our membership page, the benefits of membership, monthly webinars that are free, in-depth coding guides. I'd call this a short in-depth coding guide. We have many that are much longer, quick reference sheets and up-to-date articles. So you can be a hero in your own practice with these resources. Thank you so much for joining me today.